Sir, are you ready?
Yes, Dr. Naveen.
We'll start in a minute. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14M, which is Hematology General and Fundamental. We are streaming live from Medical College, Solan, Himachal Pradesh, via Kolkata. And today we have a very, very interesting, very pertinent, and very important topic, which is Hplc principle, technique, quality control, and application in hematology. And to talk on that, we have somebody who is an expert in hematology, a very well-known national and international person in hematology, Dr. Naveen Kakkar. He's an MBBS and MD from the famous CMC Ludhiana. Presently, he is a professor in the Department of Pathology, Medical College and Hospital, Kumarhatti, Solan, Himachal Pradesh. As you can see, his key interests are automated hematological analyzers, coagulation testing, hemoglobin disorders, hemolytic anemias and leukemias. He's got multiple national and international peer-reviewed publications, more than 83 publications. And who better than Dr. Kakkar to speak on such a very important topic, which is the center of all activity with regards hemoglobin and its related disorders. Before I ask Dr. Kakkar to start, let me request all of you to please keep your mic muted, your camera off, and at no point please do not share your screen. With this, let me request Dr. Kakkar sir, please share your screen and let us start the show. Thank you so much.
Okay, Dr. Naveen, can you please confirm if the screen is visible?
So the screen is visible perfectly. We can hear you loud and clear. Please start.
Okay, thank you. So at the outset, I would like to thank Dr. Naveen, Dr. Anita for giving me this opportunity and to be part of this very, very interesting teaching program in these trying and testing times. Now, my opening picture has something right rooted to the ground, and we'll see how HPLC has its origin somewhere there as we go on. It's a very important topic for postgraduates all over India, and we'll see why, being in India, we cannot be untouched by HPLC. And as I speak on hematology and application of HPLC in hematology, right now somebody will be talking about biochemistry applications. So HPLC is a very, very versatile tool that all subjects use. So the outline of my session, we'll just talk about the roots. How did the HPLC start? Why do we need to know about HPLC? What are the advantages and limitations? I'll give you some unusual advice that you may not find in books to remember HPLC. We'll talk about the principle and the technique, not in too detail, but just at least the broad idea. We must know what happens inside the machine, what gives us the information. And we'll look at HPLC in the diagnosis of hemoglobin disorders primarily through case studies. There's no theory here. I've got a lot of slides, but it's mainly pictures, so don't worry. And we'll end with a bit on quality control and the pitfalls while we report this, the reports from HPLC. Now that's 1981, India's first geostationary satellite called Apple that time. And you see a very sophisticated satellite sitting on a bullock cart. And they actually hired the bullock cart at that time for 150 rupees to check some satellite communications signals because they did not want a magnetic field around, so no metal. So they took it out in the field and tested it out. So the point I'm trying to make is something very basic is holding on something very, very sophisticated, even at that time. And this hasn't changed. The roots of HPLC actually came like that. So what does chromatography mean? When we say HPLC, it is high performance liquid chromatography. It's a liquid medium. What does chromatography mean? It means chroma and graphene in Greek, and that means to write with colors. Now we know hemoglobin is a colored molecule, yes, because of iron, but we don't see too many different colors, but that's not the point. The roots are in differentiation of colors, and let's see how. Now, when we talk about a hemoglobin, my hemoglobin is 14.2, yours might be 12.3, 15.5. That's our quantity. We all know that, and we deal with that more often. Now, when we look at these names, hemoglobin A, A2, and F, I know that most of my hemoglobin is A. I have a little bit of A2 and a very little bit, less than 1% of F. And that's the normal hemoglobin distribution of the quality of the hemoglobin. So we have these chains. Now you put in hemoglobin S, D or something else and you're talking about variants or hemoglobinopathies. And much like these capsicums that we are so used to, these three colors of which we know the orange and the red ones are not easily found, hemoglobin A is the predominant one. But even I didn't know till I started making this presentation that we had so many shades of capsicum. And that's the variety and more than that, that hemoglobin has as a molecule. So we know we have A2, A and F, but there are over 1,000 variants. And we know in the corona times, the COVID-19, 3 or 4 variants are wreaking havoc. But remember, hemoglobin has over 1,000 variants of its normal molecule. And they keep the hematologists busy. They keep the geographical areas dealing with more of hemoglobin disorders very busy and into diagnostics. Now, the origin of chromatography was a Russian botanist by the name of Mikhail Svet, 1872 to 19. In 1903, he actually discovered chromatography. Being a botanist, he was trying to separate the pigments, plant pigments, and he got different colors of chlorophyll, xanthophyll, and so on, and he devised a way to separate these molecules. And that's his grave in Russia. And the grave has the following sentence in Russian engraved onto it. He invented chromatography, separating molecules and uniting people. Because so many of us now deal with chromatography and its interpretation is so useful to patients and clinicians alike. Now, why should we be interested in HPLC? Why should a postgraduate student or an MBBS student or even a consultant, why should we be interested in HPLC? It's a very simple reason. We are right in the thick of it. So that's a world map that you will often see for when you want to depict hemoglobin disorders across the world. And we'll find India right in the thick of it. We have a lot of thalassemia, we don't have C, but D, E, and lots of variations, sickle, lots of sickle also, and lots of variations and combination of these hemoglobinopathies. And remember, the world has become a global village since a long time now, and no longer it is true that only in Chhattisgarh or UP you will find sickle or Odisha. Now sickle is seen in Punjab because you have migrant workers. People travel all over the world, marry across communities, and there's no area now that can say that we have predominance of this. You may have more common of one type, but you do have a mix of other hemoglobins as well. So as I said, HPLC stands for high performance liquid chromatography. A lot of people refer to it as high pressure also. Not entirely false, because the channels or the pressure pumps inside do have the fluid under very high pressure for separation. So what are the advantages of this technology? I'm talking about the hematological aspects only. So if you attend a biochemical lecture on HPLC, they'll give you a different scenario of which molecules does it allow to separate. So for HPLC in hematology, it can accurately quantify hemoglobin A, A2 and F, along with most common variant hemoglobins. It's less labor intensive. As you'll see, the processing is pretty fast, 6.5 to 7 minutes per sample. You can do a bulk processing. So in a variant, in the bigger model of the variant machine instrument, you can actually put in 96 samples in one go, program it, go to sleep, come back tomorrow, and all your printouts will be ready. And we can diagnose beta thalassemia as a single step procedure. So if you do electrophoresis, you'll have to cut the strips out, elute, calculate, and then get your A2 out. And here we get it right away. And along with the thalassemia diagnosis, you can also diagnose a larger range of variants quickly. What are the limitations? It's expensive. So the bigger variant actually would cost you about more than 20 lakhs rupees. There's a problem with coelution of hemoglobin variants. And when I say problem, there is a way around it. We just need to understand which hemoglobins come in the same channel on HPLC. Like we know for electrophoresis, S, D, G, and L are in the same band. The same issue here, but in a different hemoglobin variants, they coelute. We'll talk about that. The technical aspects. Now the machine itself is very easy. You put the sample, program, and move away. It'll give you the report. But a careful eye and experience is required to interpret, because it doesn't give you everything in black and white. There are times when you have to interpret and understand what is happening. And quite often other techniques may be required if you are stuck. So if the instrument tells you I found a hemoglobin but is not able to characterize, you might even need to go back to electrophoresis, isoelectrophorecusing, or a molecular study. to figure out what are you dealing with. We'll have one or two examples of this also. Now that's an electrophoresis strip, and we know it's your carbonic anhydrase is just beyond the point of origin, and then you have A2CEO, then SDGL, FAJBH in that order. Not everything is shown here. Now I'll give you some unusual advice to remember HPLC, which is forget about electrophoresis. And I say this not disrespecting the technology of electrophoresis, but because quite often we see students, MBBS and postgraduate students, try to remember the HPLC appearance, the hemoglobin appearance patterns almost in the order of electrophoresis, which is actually violated. So electrophoretic order of hemoglobin is not seen in HPLC. You'll see a lot of cross connection. I'll give you one or two examples on that just in the next few slides. So please do not remember your sequence of appearance of hemoglobins on HPLC for hemoglobins like electrophoresis. It is quite different, although we know that hemoglobin is a charged molecule and it's an interaction of charge with electrophoresis as well as HPLC. But the kind of interaction, the kind of technology used, slightly different. So I just put up this electrophoretic band strip created on a PowerPoint for you. So that's how the normal sequence goes for all hemoglobins put here. So we have origin here, carbonic anhydrase, A2CEO, and so on. And that's a normal electrophoretic run where you have hemoglobin A, a little bit of F, and A2CO minimal amount. And that's the chromatogram. We'll talk about this in more detail later. This is normal. A normal person's chromatogram where predominant hemoglobin is A, less than about 2% is F, and 2.3% is A2. Normal A2 is about 1.5 to 3.5%. So what I'm trying to say when I said forget about electrophoresis was do not try to extrapolate this pattern onto this. Let's see why. So here you have your origin, and the first hemoglobin that you see is A2CO. Here A2 is last. Then your F was right up there, it's first here. Your A right in the middle. And your SDGL actually crosses over. So it's already a mess. So if you try to remember this order, you will make a mistake in interpreting HPLC here. I just put this, the sequence of hemoglobins, different hemoglobins, not all of them run, some of them running together in one band, just to show you the difference in electrophoresis and HPLC patterns. So that's where the positions are. So first position you'll find these two, then SDGL and so on. While if you look at the HPLC for the same hemoglobin, it's a different pattern altogether. So you can't match 1 to 1. 1 is totally opposite, 2 is crossing over, 3 is again crossing over, 4 is crossing over, and so on. So all I'm trying to say is do not remember the electrophoretic order to interpret HPLC. So let's look at broad principles of hemoglobin disorder diagnosis. And these across technologies remain the same. You may talk about a molecular technology, electrophoresis or so, or HPLC. These principles remain the same. So the most important is ethnicity. Where does the patient belong to? And quite often we make the mistake, we're asking, where do you belong to? And they said, oh, we've been living 15 years in this place. That is not his ethnicity. He may have migrated from another area, totally different geographical area. And living here doesn't make the ethnicity different. So you must get to the roots of the ethnicity. And quite often we pick up, at least in Punjab, parents from Pakistan. So you look at the migratory patterns across the countries and continents, and you'll find a lot of hemoglobin disorders play up like that. You must have a complete blood count with reticulocytes to interpret. Never ever interpret an electrophoresis or any technology that gives you a hemoglobin disorder output. You need a CBC with reticulocyte. Maybe reticulocyte is not critical, but at least a CBC with red cell indices and RAW to make sense of which kind of red cells we're dealing with. A good look at the peripheral blood smear quite often does not have very diagnostic clues, but in some disorders you will pick up the pointers to what you're looking for. In case of a doubt, if your subject is young, please do parental screening. It's a very important tool when you're stuck in figuring out what are you dealing with. And when we got HPLC and CMC many years back under a project, we thought we got the answer. And in the next 3-4 months only we realized, no, we'll have to still keep our electrophoresis going and even depend on other techniques. So remember, no single technique is enough. It will give you a lot of answers, but it will also throw up an odd question. And our job as a pathologist or a hematologist is also to look at the clinical queries to sort out for the clinician and the patient. So you must be able to say, whatever you have found on your HPLC, is it going to be asymptomatic or asymptomatic? And the clinician will already have an idea of that. You need to correlate. If there are symptoms, what is the profile? Are there mild symptoms? Is the patient very symptomatic? Is there a spleen or is there not? Antenatal diagnosis is a very special scenario just because of the need for an emergency situation at times. So if the lady turns out to be a thal trait or a sickler, then you're around 10 to 11 weeks of pregnancy. Quickly test the husband, and then you have to decide on this chorionic villus sampling if required. So quite a lot of times in India, you'll find the antenatal patients landing up pretty late, beyond the time of intervention. Still counsel them, because at least for the next pregnancy, they can be careful. And like you said, a lot of this has genetic implications. So your reporting has to be very, very precise. And if you are in doubt, please ask for a second technology to confirm what you're dealing with. You also need to probably tell the clinician, do we need a prenatal diagnosis in this situation or not? In thalassemia, when both partners have thal trait, it's mandatory. But remember, if thal or a thal combination with the hemoglobin D may not be required, because you'll either transmit a D or a thal trait directly. And that will not cause a clinical significant anemia. Your prognostication is often not without molecular testing, especially in thalassemia, because a major is a major, but we know majors can be of 20 types in terms of their transfusion requirements, depending on the kind of mutations that are matching up. So what's the principle of Hplc? It is separation of hemoglobin and its variants, each having a different charge. So when we say hemoglobin, we know this hemoglobin breaks down into different parts, A, A2 and F, and other variants if there are, and each carry a different charge, and they then bind to a stationary phase, which is the column. I'll show you pictures of that. And you have a mobile phase, which is a buffer, which then competes for the binding sites in the stationary column. So I use this example which I heard last year. So just imagine this is a rivulet. We obviously see leaves, and let's say I talk about this pebble. So imagine if I had leaves in my hand along with the pebble and I threw them into this rivulet. Now just by the weight, the pebble will settle down, and if the water is moving fast enough, it will tumble down a bit, but the leaves being very light will go fast. Now imagine this is your lighter hemoglobin or a less, or where the charge is less. Here your more charged hemoglobin that the buffer cannot elute out, that stays in the column for a long time. This comes out from the column in a faster time. So we threw them together. We are able to now get them out based on their different attachment or attraction towards, see the bed here. So imagine the water there was the mobile phase, the strong binding was the pebble, the leaves were the weak binding. So leaves will actually leave out faster from the column, while the stone will stay for a longer time, it will come out later. That's the basic principle of Hplc. So what is there in the column? So this column has negatively charged carboxyl molecules which are bound to silica, which is made up of this cartridge matrix. So this cartridge looks like this, like a bullet, long cylindrical thing, and it has packing material, microscopic, that you can't visually see directly, but this is with negatively charged molecules. So hemoglobin binds to these. So imagine 4 types of hemoglobins are now bound to this. Then we throw in the buffer, which is a liquid medium, and that, with the differential capability of the charge attraction, throws out some hemoglobins faster than the others, and that's how they come out separately. That's a good example to show you. So at the injection site, we have the sample lines, which are the hemoglobin ions, and that's your the column. So when we inject the sample into the column, it binds to the particles there, the silica particles, so there is absorption. When you then throw in the buffer, which is the mobile phase, there is competition for the binding sites. And some hemoglobins come out faster, some come out later, hence they are separated. That's a Biorad D10 instrument, a smaller one. And this is the variant one on which I have done quite a lot of work earlier. Now variant 1 is not in use anymore in most labs. You will find variant 2, but the basic principles are the same, so I'll just take you through this instrument. So that's Biorad is a company, variant hemoglobin testing system. They're the most well-known company for hemoglobin testing systems, although there are others also now in the market. It doesn't matter which one, they do the same work. So there is a buffer system. So this is buffer 1, behind this is buffer 2, and there's a wash buffer. After the end of each cycle, it washes or cleanses the pipes. So 2 buffers with different ionic concentrations provide the liquid phase. That's your sample well tray, and that's a needle that aspirates. So you can actually put distilled water, primer, calibrator, quality control, and then we have 96 wells free for our sample. And once you program, this probe will actually move and aspirate automatically one by one and give you the reports at the end. How do you prepare a sample? One of the easiest methods. Remember, in electrophoresis, you need to prepare a hemolyzate. You need to spin your sample after directly throughout the plasma, wash it with the normal saline 3 times, and then get the hemolyzate out. Here it is very, very easy. Take an EDTA sample. The kit comes with a hemolyzing agent. You need 1 ml of that in a Eppendorf tube. Take 5 microliter of whole blood, mix it, keep it for 2 to 3 minutes. Your hemolyzate is ready for a run. That's it. So no cumbersome preparation required. It's a very easy technology. That's the part of the instrument that I'll show you some more in detail. So you see some steel bodies here, and something in steel here, something black here. We'll go through these one by one. So these are pumps. So that's pump A and pump B. We have dual piston pumps. So these are the ones that create that high pressure under which the separation occurs through the column. So pump A and pump B, dual piston pumps. Remember the pumps over here. This is where the thermo cartridge is housed. So if you unscrew this, you will find a long case where you can actually place the cartridge. This is how the cartridge looks like, or the column, and you place it at both ends here, so across the end. So this, when the pump throws in the fluid with containing all hemoglobins, it is separated out in the column and then moves out through the other tube. And the output from the column then goes to the detector. So that black part is the detector, and this actually looks at the hemoglobins coming in at different times, and by their wavelength decides which one is which. That's your display screen and the programming screen there, and that's one run in progress. So sample number 3, we are running the beta thiol short program. I'll talk about these as in the next few slides. That's a flow rate 300 psi per square inch. That's very, very high pressure. The column temperature is very important because it decides on the good separation or not. Cooling temperature is where your sample is kept, so it's kept cool. So even if you're going for a run that is going on throughout the night, your sample is kept cool, it doesn't degenerate. And you can count how many samples have gone through the column. And that's your output coming out. One report comes out after 7 minutes or so. Now, before we go on to case studies and just a basis about interpretation of the normal chromatogram, what does it give us? It seems complicated with too many numbers, but it's basically pretty simple. You need to learn about 2 important terms here. One is the retention time and the retention window. Now, just remember, time is a single time. Retention window is a range. That's it. So if I have a time x, then x1 to x2 will be my retention window. Let's look at these examples. So it's measured from the time of sample injection to the maximum point of each peak. So in this chromatogram, let's pick A0 or the normal A. That says 2.53 is the retention time. So this time is the retention time. And if I draw a line dropping down from this, right here, top of the peak, where are we? About 2.5. So that's your retention time. Time of sample injection to the maximum point of each peak. And the time starts here. So on this axis, what you have is time in minutes. This is your percentage of hemoglobin. Retention window is a time in which that particular hemoglobin is likely to elute or come out. Which means if the retention time is 2.5, then maybe 2.2 or 1.9 to 3.3 will be the window in which this hemoglobin is expected to be out. So I'll give you some examples of retention windows. You don't need to memorize this, but just remember some parts of the sequence. So let's say A0 is 1.9 to 3.3, F is much earlier, A2 is beyond that, and then there's a pattern. D first, S first, and then C. So if you see 4.1 to 4.2, 4.4 to 6, and so on. There are minor changes in these with different kits. So please do not quote me on this is hard and fast, because if you get another kit, your retention time may be 3.65 to 9.5 and so on. So it changes lot-wise or kit-wise, and it's important. But your more or less sequence will be the same. Another thing to look at, the total area. So when the instrument is able to give the percentages of all, it actually totals the total area, and that is here. And this needs to vary between 1 million to 3 million. If this is beyond 3, this is 2.4 million. If this is beyond 3 million or less than 1 million, your hemoglobin estimation could be wrong, and you need to dilute or concentrate your sample. So what are the programs available? I showed you on the printout, if you see here, that's the beta thiol short program, which means we have bought the beta thiol short kit or the program. What does this mean? Will the alpha thiol short not give me beta thiol rate? That's not the case. So the point here is, it will highlight what you're asking for. So here I'm asking for mainly, if I'm in a thal bed, I would use this program. If I'm in China or Philippines, dealing more with alpha thalassemia, I'll use this program. If I'm in Odisha, I will go for sickle cell. If I'm doing research, maybe globin chain. Or if I want to do A1C estimation and hemoglobin variant, then I'll take a dual program. So all it means is, it will pick up so it is that if I'm using the beta thal short program, it will also pick up sickle cell. A sickle cell program will also pick up beta thal, but it won't highlight it. We just need to sort it out ourselves. That's it. So when we diagnose, how do we do diagnosis in HPLC? Going back, please look at the CBC and peripheral blood findings, because if I'm dealing with a beta thal major type of chromatogram, I would want to see gross microcytosis, must correlate. Ethnicity and place of origin of the patient. Look at the peaks. Are all the peaks normal, which is expected, or is there a new peak? Very important. We said now, all normal hemoglobins or normal persons will have A2 and F as our main peaks, A being the major one. If there is a new peak, you're dealing with a new hemoglobin. So that's one thing to look at. Then look at the location of the peak. Where is it? And as we look at the chromatograms, it will make this clearer. So in relation to the other normal expected peaks, where is this peak located? What is the width and height? Which means basically you're looking at what percentage of hemoglobin is contained in this new hemoglobin. And your total area should be, like I said, 1 to 3 million. If you have the parents, please do a pattern on parent sample if available, if you're getting stuck on the diagnosis. We talked about coelution. So remember, in electrophoresis, hemoglobin S, D, G, L came out in the same band. Same way A2CEO you'll see in the same band. While in the HPLC you will find LEPOR, hemoglobin E, and D, Iran coeluting with A2 as your major area. So that's what we deal with often. You'll again see examples of this. Again, as a general guide to interpretation before we go into the chromatograms, remember the hemoglobin disorders are two types. One is thalassemias, another is hemoglobin. Please do not use them interchangeably. Thalassemias mean you'll still find it's an interplay of three hemoglobins, A, A2 and F. There's no new hemoglobin. While in hemoglobinopathies, you're dealing with a beta chain or an alpha chain variation where you find a new hemoglobin coming up. So once you deal in thalassemias, what is the problem? Less alpha or less beta chains, different proportions. Hemoglobinopathies, a new hemoglobin coming up, and that reduces your major hemoglobin A. And again in this, if you look at S, D and C traits, your percentage is likely to be around this. A little bit up and down is possible, but usually 30 to 40%. Hemoglobin A in these cases more than 50%. If you deal with the homozygous disorders, your percentage goes up markedly. But remember, HBE trait might have a slightly lower trait value, although homozygous is similar. That is because it has a small synthesis, it's a slow synthetic chain. So E synthesis is slightly slow, almost like a thalassemia component, but your trait values are likely to be slightly lower than usual S, D and C. Let's look at what is normal before we go on to the normal chromatograms. So I showed you this. So in this, if you look at your values, that's F, P2, A0 and A2. Now P2, you might even find a P3 in some chromatograms. P2 and P3 are minor glycosylated peaks. So if this is F, which is highlighted here, the smaller peaks here could be P2, or just beyond that here, sorry. So this is P2. You might even find another one saying P3. If you are looking for a hemoglobin disorder, I am not worried about the glycosylated hemoglobin, let them be. But if they are coming out to be say 12 or 15%, then you might even be picking up a diabetic just by chance. So again, if you go to biochemistry and they are using the A1C program, their instrument will highlight this hemoglobin, the A1C, and will not give you the measured or shaded portion of the others. So basically what program are you using will highlight what you are looking for. Again, F, A2 and A0, your main peaks, and A0 plus P2 is actually your total hemoglobin A. Another thing to remember, you'll find F and A2 given to you again. So the same value actually is given to you. So that's a summary of this report because you're running the beta thal short program. In the beta thal short program, I am looking at A2 and A and F, and it summarizes those programs or those values for you again. And like I said, percentage of hemoglobin here and the time here. And so the faster hemoglobins come out here and the later ones we'll find them coming out later. So let's go to the cases straight away. I've got about 14 cases and then 4 pitfalls, and that's it. So there's a 35-year-old male, came for a routine CBC, and I'll just highlight what is abnormal in the CBC quickly. So you find for a 35-year-old male, he is anemic. Not too bad, but yes, anemic. RBC count is really high compared to, for a hemoglobin of 10.6, I would have expected maybe 3 point something. It's 5.74, almost touching 6 million. Gross microcytosis, MCV is 61, RAW is normal. So with these parameters, my diagnosis is probably a beta thal trait. Why? Why not iron deficiency? Because there is gross erythrocytosis. For a hemoglobin of 10.6, 61 is too low. Hemoglobin should have dropped more. And an RW of 14 means hardly any poikilocytosis, which you see in iron deficiency. So here the indices are actually pointing out to a diagnosis of beta thal trait. So what do we see on the chromatogram? So I've hidden the values and I'll release them as you go along seeing them. Again, if you look at your F, P2 and P3, don't worry about them. Look at your F, your major A and A2. And A2 seems a bit raised, although it's difficult to say just on the chromatogram, you need to see the value. So there's no fun in hide and seek here. You will get to see the values when you report and you make your diagnosis on that. So that's a normal one on comparison. And what do we have here? And fetal of 1.1 and A2 of 5.8. And A2 of 4 to 9% on Hplc is diagnostic of beta thal trait. So this confirms the diagnosis of beta thal trait, very, very obvious. Minor or heterozygote. Case 2, this is a 5-year-old male with pallor and splenomegaly. Again, let's look at what are the grossly abnormal findings. There is severe anemia, gross microcytosis, RAW which is very high, tells me there's a lot of poikilocytosis. Even if this was severe iron deficiency, what goes against? A very high RAW. Severe iron deficiency, you can probably hit an RAW of 21, 22, maybe 23. But 28 means too much of poikilocytosis. Splenomegaly, you don't see an iron deficiency. Pallor, yes. So a clinician will already be starting thinking of probably a beta thal major. So what do we have here on the chromatogram? This is the area for our normal A. It is markedly down. Remember the shaded ones are going to be F and A2 on this chromatogram. So A2 seems normal and F seems to be markedly raised. So it confirms your diagnosis of beta thal major. And your fetal hemoglobin is almost 97% here. Your A is 5.8, markedly down. And A2 is 3.3. Remember in thal major, the A2 diagnosis does not contribute to the diagnosis because it may be normal, slightly raised, or even low. It does not contribute to the diagnosis. You need your fetal hemoglobin. So that was beta thal major. Again, remember, when we call it major, I need to have the clinical profile. In terms of if this patient is requiring a transfusion only twice a year, then he fits into the thalassemia intermediate phenotype, not major. Although this kid landed up to be thal major. Case 3, this is a 25-year-old lady. This was a pre-immigration CBC. Everything seems normal, no problem there. And what do we have here? That's normal for comparison. Again, so remember we said hemoglobin disorders, thalassemia, interplay of these three only. But what we have here, there is some F, there is A2, there is some A which seems reduced. There is a new hemoglobin coming up. So that's the variant that you're dealing with. It is just beyond A2, say about 4.1, 4.2 is the retention time. You can actually see it here. And that is our zone for hemoglobin D. So that's hemoglobin, and the machine will actually tell you. So it flags for you that this is the D window with a 37.4% hemoglobin situated there. Retention time is 4.2, which is classical range for hemoglobin D. And that's hemoglobin D trait. And if you go back to the indices, absolutely normal. That's how HBD Punjab is. Indices are normal. You will not suspect this. There are no symptoms. Case 4. This is a 35-year-old male. Again, asymptomatic. Indices are normal. Nothing to suspect here. Again, compared to normal. Looks like the last one. If you go back to this last one, looks like similar. Right? So again, there's a new peak beyond A2. But this seems slightly further up. So if I again drop from the mid and try to see what is the retention time likely, it's close to 4.5 something, right? Midway. The earlier one was somewhere here. So the slight difference is important. It's important in electrophoresis, it's important in Hplc also. So this is actually the S window. So the machine actually flags it for you and says this is an S window. So hemoglobin S falls in this zone or this retention time. F and A2 do not seem to matter here much. Retention time is 4.5. So what do we have here? Hemoglobin D was about 4.2. 4.5 is S, and the next hemoglobin will come further up. So that was hemoglobin S trait. Case 5, this is a 38-year-old lady, pre-op cholecystectomy. We did the CBC, found microcytosis. For an MCV of 70, RW is not much raised, so we don't know the cause of this microcytosis. The gross abnormalities are a low MCV and low hemoglobin. What do we have here? That's normal for comparison. And now if you see your A, this was the A between say about 2 to 3, it's almost down to the base. A is gone, A2 is there, and you have a new peak there. Now let's see and try and drop, the midpoint to see the retention time likely. Coming down here. Again about 4.1, 4.2. And the machine actually is telling you there is a D window. Remember, the machine did not tell us trait or homozygous. We have to figure it out by percentages. So the D here is 88.2%. Unknown 2 or unknown 3 are minor peaks degradation to be ignored. A2 is 2.4, fetal is 1.3, and this seems like a D homozygous, where percentages are 85 to 95%. Your A is virtually gone. So that was actually D Punjab homozygous. These patients have microcytosis, but otherwise they are asymptomatic. Now, a word of caution on this case only. I just want you to see carefully in this zone. So if you see, the D peak as it lifted up has also interfered in the A2 peak. So A2 seems a bit incomplete and stretched. Now this is telling me that the A2 estimation, whatever I'm seeing here, 2.4, may not be reliable. So actually speaking, this could be a D-Thal combination. One of the parents could be D-Thal, Thal trait, other could be a D trait, and this could be a D-Thal. In which case your D will behave like the percentage behaves like a D homozygous. And in this case, your A2 is normal, which gives you a false sense of security. But looking at this pattern, where it seems like the A2 has been cut off in half because of the lifting up of this D window, I want to do an A2 by another method. And if your A2 is say 4.8, 5.2, then you're dealing with a D-Thal and not D homozygous. Both peaks may look alike, your A2 may fool you here. That's the important thing to remember. Now, why is it so important? Because if it is D alone, there are no antenatal implications. D trait will not cause anything, D homozygous will not. But if one of them was D-Thal trait, then you're passing on Thal trait to one of the kids, and he lands up with a chance of marrying another with Thal trait later, and you could have a thalassemia major problem coming up. So remember, D homozygous on Hplc, please look at A2 carefully. If it is raised, well and good. If it is not, you still might need to do it by electrophoresis or another method to be sure about the actual A2 value. Case 6. This is a 21-year-old male with recurrent joint pains and jaundice. A typical history of a sickler. Hemoglobin is pretty low. Microcytosis, RW is raised. There you are. And what do we have here? Normal. And you have a peak. Again, your A is gone. So roughly between 2.5 and so, your A is down to nothing. Instead, you have all the hemoglobin, most of the hemoglobin here with the slight importance of A2 there. And again, if you drop down and see what is the retention time likely to be, this is again 4.5, which was what? For sickle hemoglobin. So again, the instrument tells you this is sickle, S window, almost 90%, 4.38. So about 4.4 to 4.6 is the sickle hemoglobin time. So that was HBS homozygous. Case 7. This is a 27-year-old male, African student studying in the Delhi University. Indices are normal, absolutely normal. There you have a chromatogram. I don't have the values for this, but I'll give you the final outcome. So you have F, P2, P3. A good amount of A is there, some A2 is there, and there's another new peak. So obviously this is not thalassemia. This is a new peak, means a variant. And where it is, if I drop in the retention time line, just less than that, about less than 5. So 4.8, 4.9. And this is typical for C, hemoglobin C, and this was 37.3%, and that's HBC trait, not seen in India, only about 2 to 3 cases reported. Now, if you look, we don't use these cameras anymore. Everybody's into mobile cameras, 4 of them in one mobile actually. But if you took some pictures with this camera, or if you remember, then the output would be stored like this, DSC. And that stood for digital still camera, and then the number of the photographs. That's the output that we would get when we store these images. So remember this sequence, D, S, and C, because on your chromatograms, if I go back to, let's say, any of these ones, so beyond A2, just beyond 4.2 is D, 4.5 is S, and 4.9 is C, DSC. So remember this sequence, it's easy to remember. Digital still camera. Okay, case 8. This is a 40-year-old male who's asymptomatic, normal indices, a borderline MCV but not too bad. So again, you see a normal chromatogram for comparison. Now we are dealing with difficult areas, slightly difficult areas which need a little bit of thinking to interpret, but once you understand what is happening, you will interpret. So what is happening here? We said no new peak. There seems like a big peak, but it's in the A2 area only, right? So we have your F, P2, P3, glycosylated, that can be added up into this for normal. We have a good amount of normal, and we have a small amount of A2, which is markedly raised than your normal A2. Normal A2 is only till here. Here you're getting an A2 just up there. But if you look at, so even though the heights may be same, the heights of these two columns appear same, but the area under curve is much more in this. So this one, this hemoglobin will contain much more hemoglobin in percentage than this one for sure. So there is something which is coming along with A2. It cannot be A2, so it cannot be thialtrate because thialtrate range is only about 9%. This seems to be more than 9%. Let's see how much it is. So it's 29.8%. So something co-eluting in the A2 region or coming in the same region is interfering. And this, if you take out the actual A2, which may be 3% or 2%, you're left with about 25-27% of this variant hemoglobin. That's an assumption, right? But you're dealing with at least a total of less than 30. So this is a co-elution. With this percentage, it has to be E trait or an E heterozygote condition. So that's hemoglobin E trait. Why did we say that? Because the A2 for thalassemia needed to be, say, about till here only, 6, 7 or 8%, maybe 9. But this percentage has to be something else. And in this percentage, in this area of this range is E trait. E is often seen in the northeast, Bengal, Calcutta, etc. Case 9, 30-year-old with pallor. So let's see what are the abnormalities in the CBC. There is good amount of anemia, MCV is markedly low, REW is high. So expect microcytosis on the smear. When you run the Hplc, this is what you get. This is not the image from my collection. I borrowed this from the net, from a paper from India, so I've just referenced them. So that's again F, P2, P3, and your A is gone. Instead, you see a hemoglobin again in the A2 region. So virtually all your hemoglobin is in the A2 region. And this was actually, hemoglobin A2 is 84.9%. So like we saw in the last case, about 20, 25%, 30% was E. So in the same region, anything going up to 85, 90% is E homozygous. So that was E homozygous there. Case 10. This is a 20-year-old lady with antenatal screening. Again, you look at the parameters, everything is fine. Now, let's try and sort this out without the values first. There is a little bit of F, P2, P3, your normal A, normal A2, and then you again have a new peak. Remember I showed you the hemoglobin C trait, which was just about here, almost 4.9, 4.8%, right? This seems like that, but this peak appears very narrow, very tented. So in fact, if I go back to the C trait, that would be maybe this wide. So the width of that was probably double than this. What does this tell me? That this peak, although taller than this, contains roughly half the amount of what I saw in the C trait. In the C trait, we saw about 37.6%. This seems to contain about half of that. That's my guess. The machine will give you a percentage. You can actually evaluate that. So it gives me that. Now the problem is the machine is not able to identify what is the hemoglobin. So somewhere here it would have called out D. Somewhere here it would have said S. 4.9 it would have said C, but this hemoglobin with a retention time of not 4.9, lesser than that, about 4.76, just slightly inside. Percentage is about half of what I saw in C trait, so this is something else. Now that is where your knowledge of the hemoglobin disorders prevalent in your area and taking help from the Bio-Rad library where they give you examples of other hemoglobins comes up handy. And once you diagnose one or two of these, the next time you are able to say what this is very quickly. So this is actually hemoglobin Q India. So the machine will not read it for you. It will give you as an unknown in this region and you have to sort it out by retention time and the percentage. If this was say 35%, I would think of something else. But I know an unknown in this region with this retention time and a percentage about 12 to 20% is usually hemoglobin Q India. It's a completely asymptomatic variant, will have no implication at all for a prenatal diagnosis also. So hemoglobin Q India is not very uncommon. We see it often in Punjab. Case 11, this is a 49-year-old male, came for a routine checkup. All indices are normal, nothing to worry from the CBC. Now let's see what do we have here again. Little bit of F, P2, P3, and your A2 is, again we see there is a hemoglobin come out with A2. So this is called typical coelution. There is an hemoglobin which has come out with A2. What I want to emphasize in this picture or this chromatogram is, I'll give you the values and the answer. If you see these two, they are virtually mirror images of each other, except that this one is shaded. So on variant 1, whenever we got a hemoglobin D, and this is not the, remember D Punjab was beyond this. D Punjab would be somewhere here. So D Punjab peak is expected here, not this, but still this is D. So the instrument is actually calling it out as A2 because it falls in the A2 region. The S window is 0.8, that's nothing, that's just slight interference here. So the instrument is calling it as A2, and we know that A2 of this percentage with this retention time, the coelution answer is hemoglobin D Iran. So what does this mean? This is not D Punjab, this is D Iran which coelutes with the A2 region. Now I remember we had about 7 or 8 patients of D Iran. All their chromatograms were actually almost like carbon copies of this, mirror images. That's a very important clue that what you're dealing with, percentage wise also. So let's quickly go to the percentages on A2 coelution that we've done so far. Hemoglobin E about 25 to 30%, 40% and slightly beyond is D Iran. Then if you go up, you will have about 85 to 90% E homozygous. So this was hemoglobin D Iran. Again, doesn't have prenatal problems of diagnosis or complications in the children. And it's again not very uncommon, but less common than D Punjab. Patients are asymptomatic, have normal indices like our patient here. Case 12, this is a 24-year-old lady, came for antenatal screening, mild anemia, microcytosis, and here RW which is normal. So for a 9.6, MCV is pretty low. So my guess on the indices would be I want to rule out a thalt rate, simple. So that's an abnormal area to look at. Now, what does this show me? Fetal is slightly raised, good amount of A, about 76 plus your P2, P3, 8% or so. So about 80% plus is A. My A2 is 12.6%. Now, the indices suggest thalt rate. My A2 suggests something else. Why? Because we said normal A2 is 1.5 to 3.5%, 4 to 9 is thalt rate, and 9 and beyond will be something else. So this is beyond 9 for sure, this is something else, and this is hemoglobin Lepore rate. So Lepore is not very uncommon in North India. You find odd cases, and they usually confuse it with the indices being completely like beta thalt rate. But when you do their values, if the A2 is raised like this, it is a hemoglobin Lepore rate. Case 13, an 18-year-old male with sickling symptoms since 12 years of age. Since 6 years of age. So since 12 years, he's had sickling symptoms, anemia, mild microcytosis, and a slightly raised RAW there. And that's the values. So if you see fetal is raised, A is down, and we have A2 is raised, and we also have, so again, I'm dropping the center value for the retention time, down it goes. 4.5 was our area for S. Machine itself is telling you S window 80.7. With this amount of S hemoglobin, that's the reason why the patient is presenting with sickling symptoms. Now the issue here is, now with the raised hemoglobin S, you can get a compensatory F rise. But here your A2 is also raised. Right? So A2 is A2 is a Thales range. So what does this tell me? So luckily we had the father and mother of this patient. The father was a Punjabi, the mother was from Nigeria. So the father actually had beta thalt rate classical, the mother had a sickle trait. So the combination gave rise to, so let's see these values. The father had an A2 of 6.2% classical beta thalt rate. The mother showed up an S window of 35.9. So you're dealing with an S trait marrying a thalt trait. And what happens? You get a sickle beta compound heterozygous state. So one important point that I want to emphasize here is, whenever you get a Thalish component merging with a hemoglobinopathy, your rules for homozygous and especially heterozygous goes for 6. So we said the mother is sickle trait. What are the rules? About 30 to 40% sickle, she has that. But when she transmits the trait to the son, in combination with the THAL, your S window now becomes almost like homozygous. So that's important to remember. Whenever you are finding unusual findings, so unusual finding here is an A2 raised. And that tells me probably, so luckily we had the parents, we could sort it out. Otherwise, he was actually labeled as a sickle cell disease patient outside and being treated, which is not wrong because he's sickling. But the origin of the sickling is a compound heterozygosity here. So actually got the worst from both continents. So we were dealing with an S-beta thalassemia or a compound heterozygosity of this. That's the last case before we go on to some troubleshooting in QC area. So 9-year-old boy had pallor and splenomegaly. Let's see what are the normal findings. Severe anemia, gross microcytosis, very high RAW. Anybody will say this looks like a THAL intermediate or a major. And if he was transfusion independent, so THAL major probably. Now, this is what we had. Now, if he was pure THAL major, you would find all the hemoglobin in the F region, right here. But he seems to have again something coelution in A2, and which seems to be more than F, just by the, again, don't go by the height of the peak, go by the area under the curve. So there is something coeluting with the A2 window, which is more than F. Let's see what this turns out to be. It doesn't tell you much. F is 31.3, the A2 is 58.1. Now what coelutes with A2? That can give rise to a thalish-like component with a fetal rise and presentation like THAL major. This has to be hemoglobin E. So this patient's one parent had hemoglobin E trait, the other one had THAL trait. So again, this is, if you go back to your S-beta example, again your trait rules are gone for a 6, so E trait would be about 30%, here it is gone beyond that, because it is now married a thalassemia component. So this patient was transfusion independent, behaving almost like a THAL major, but he was actually an E-beta thalassemia. Now, quality control. We're so obsessed, and the industry, your manufacturer are so obsessed with quality control. It is important that we are also obsessed in the lab, especially dealing with a test which has so many important genetic implications. So when you look at quality controls, look at all 3 LMs. So in the pre-analytical part, look at the sample quantity. If your sample quantity is very less and the instrument is not aspirated much or your amount of hemolyzate is less, you can get erroneous values. What was the storage? What was the hemoglobin of the patient? If the hemoglobin was very low, you might have problems in the area. Remember we said area should be 1 to 3 million. You can have less area and wrong values. Recent transfusion history, very important. So we've had this about 3-4 times now. We've reported normal Hplcs and then found out that the patient had been transfused. So some of the clinicians are not careful regarding this history. So whenever you're receiving a sample for Hplc, please ask for a transfusion history, because then you will be actually chromatophorizing new cells, new red cells, which will give rise to normal values. The patient may have been actually having a THAL trait or something else. Analytical problems in the machine. Your sample injection issues, cartridge temperature, very important for the good separation. The pressure, if the pressure falls, there is a leak, you may have problems in separation. Post-analytical, I'll give you 1 or 2 examples of this. Interpretation errors. You must need to learn to look at peak patterns, the shape of the peak, the width, is it touching the baseline, the area under the curve. So all these are important areas to look at in a chromatogram once it comes out to you. And you can use internal quality control methods, you can use commercial controls or in-house controls. Now, in-house controls here are, if you're running a slightly high throughput area and you get frequent samples on Hplc, let's say I picked up a hemoglobin D in my last run, I would preserve this sample. You can keep it for about almost 2 weeks or sometimes more and then run it with your next run. So it will give you a D separation very easily. And you must enroll onto an external quality assurance program. Just examples of both. That's the internal quality control commercially that you can get, and you can get this for both the hemoglobin A2. You have 2 levels, and you can even get it for A1C if you're running that program. And that's the EQUAS or the external quality assurance program that is being run by BioRad again. And you can upload the results, they compare with other labs and give you a report on the Z score or the deviation. And say here the result of most labs was about 2.9 to 3.1%. There the lab was 3% here. So that you can check and do an internal check and an external check about quarterly there. Now, 4 scenarios where there are pitfalls in interpreting HPLC. What seems like a very powerful, fast, and a rapid tool does have some pitfalls, and we need to understand the scenarios where these are likely to happen. Some of them are pretty odd, so we need to just be careful while we interpret. Now, this curve is very fascinating for kids. From far, they'll see and they'll jump. I want this. So let's look at area under curve. Remember, we talked about the area under curve should be 1 million to 3 million. So scenario 1. Same sample, run again. The area under curve here is less than 1 million. Okay, here it is 3.2 million, just above, but at least not that low. So this is about 70,000, not 7 lakhs low. This is just about 2 lakhs higher. So this is more acceptable. What is the problem here? The sample's hemoglobin was very low. So if you see the interpretation here, the A2 peak is very, very minor. Here the A2 peak is good, well interpreted. Now, what can be the problem here? If you see, the A2 reported here was 4%. That is just because the concentration was lower and the linearity limits of the instrument here it has difficulty reading below this concentration. So it reports an A2 of 4, which becomes phthalate, while here A2 is 2.8. So area under the curve is one important parameter to look at here once you look at your chromatogram. Now in maths, when we did this exercise, what did we call this? We said carried over. So carryover is a phenomenon in automated analyzers. It's also a phenomenon in HPLC. Let's see one example. You must not get carried away by a high value. These are actually lab numbers for our lab that time. Sample 222 turns out to be A2 coelution, and this was a hemoglobin E trait. Right, so here your A2 is about 40%, and a little bit of less than that will be actual A2. The rest is hemoglobin E. So it looks like an E trait here. No problem with that. A2 is 40.6. My next sample, which with normal indices, is reported as phthalate, 4.8. That's the next sample, not the same patient again, new sample. So I'm going to report this as an A2 of 4.8. But I looked at the CBC, absolutely normal, no indication of microcytosis. We did the sample again. So repeat value is now 3.2, absolutely normal. So what is the problem? This coeluting hemoglobin here in the same region of A2, the E, traces of E have been left behind, and that contributes to the A2 of the next run. When I do one more sample, it is washed off again, and now we get believable and normal values. So a carryover phenomena here. So whenever you run a hemoglobin which has coeluted, check the next value of that, the next sample also. In case there is a problem, doesn't match with the indices, please run it again. Scenario 3. This is some magic that we did in our lab. That's the history we got. 2-year-old girl, transfusion-independent anemia since 6 months of age, and hepatosplenomegaly. Everybody will think of beta thal major, nothing else. The CBC virtually confirmed that. Gross anemia, gross microcytosis, very high RW, signifying a lot of poikilocytosis. Clinical diagnosis was beta thal major. Now the HPLC report that we got from outside was this. A was normal, A2 was 1.8, fetal was nil. So the clinical person was stumped, so were we. So the clinician in our center reorders the HPLC from our lab. This is what we report. What we have done is virtually switched everything. A is 1, A2 is 2.7 normal, but fetal is 96.3. And that's what I call magic. Let's see how we did it. So what magic did we do? That's the outside chromatogram that we received. This was run on D10, not the variant one. So if you see a little bit of A2, A is virtually gone, and everything is concentrated in there's no F reported if you see. There's the LA1C, which is the glycosylated part. That's our center. What do we have? Virtually similar, nothing different. So actually we did not do any magic, we just interpreted this correctly. So there is, again, if you look, there is no F generated. And that is the pitfall that the outside lab had. Because they saw no F, they reported everything as A and A2, and F was 0. So we looked at the library of chromatogram, the D10 system. What does the chromatogram say? It says on the D10 hemoglobin testing system, if your sample contains a hemoglobin F more than 16.5, it may elute in the LA1C HB window or A1C and no HbF will be reported. So it's a technical limitation of the instrument where very high F hemoglobin is co-eluted in the glycosylated area. So hence, it did not find any F, did not report it, but although all this was F only. So the report actually which the private lab gave, all this meant was this was actually F, this was A, and this was A2. They had the correct chromatogram, but was not interpreted correctly. No magic really. Last, this is scenario 4, and I said we should not rush things. So we got this chromatogram, it's from an antenatal lady. I think I'll give you the history. 26-year-old antenatal screening. Hemoglobin was 10.1. The rest were normal, no CBC abnormalities. We got a hemoglobin S of 37.6. So if you see here, this is the D10. So it's like your retention time is slightly different. We got a hemoglobin S window, and that S window is 37.6. The retention time was slightly beyond the usual. So we withheld the report, wanting to check the sickling test. So we wanted to get the PG student to do the sickling as a learning exercise, got it done, and it was reported as negative. We said, please do it again, do it properly, reported again as negative. Then we got it done by our most experienced technician in the lab, still negative. So what are we dealing with? The instrument is calling it S, we think it is S, but our sickle test is negative. We sent the DNA to a higher center after we confirmed by ARMS PCR that the sickle mutation with us was negative. So what did this show? This showed a new variant, a rare variant called hemoglobin rush. Hence the name of my slide, do not rush things. Hemoglobin rush, and at this position, at codon 101 of exon 2, that's the mutation that you're seeing, heterozygous. Now, going back, we looked at many other, actually we have chosen 3 here. We looked at other chromatograms of S traits that we had reported. So if you look 1, 2, 3, and this is hemoglobin rush. So if you see, this shoulder has a bit of a trail, which is absent in all others. So there's a slight chromatogram difference, very fine one that we were not aware of, which made us call this S initially, but obviously the sickling test being negative was important. And then we were lucky that we had the ARMS PCR, proved that the sickle test was negative, the sickle mutation was negative, and then could get the higher center to do sequencing for us for the diagnosis. So that's hemoglobin rush there. And so again, in the mental block, if you have a mental block on reporting sometimes, these things help. Next time I would want to look at the slope of the S chromatogram also, or the S peak. If it is wide and I'm looking over a sickling test negative, you're probably dealing with hemoglobin rush. Now remember, this is an extremely rare event. You'll probably find this 1 in 20,000 samples. But important to understand, the slight variations in normal patterns may mean something that we may not be aware of. We just need to be worked up well. Okay, to summarize, Hplc is a vital and rapid tool for the diagnosis of hemoglobin disorders. Like we just saw, you can figure out pretty much quite a lot of common things. And remember, in India, what are we dealing with mostly? Thalassemia, minor, major, hemoglobin D, Punjab, D, Iran, Q, India, S, E, and compound heterozygotes of these. The rest are less common. You must know about retention times or the sequence or windows of common hemoglobin disorders. That helps you to sort it out. Please do not forget the basic approach of going through the CBC, geographical area, ethnicity, and so on. Now, I give you 2 examples here, which are odd situations. We had a patient with the hemoglobin E trait from Punjab. Now, Punjab is not a belt for E. We kept on asking for history. Are the parents or grandparents from anywhere from Northeast or Calcutta? The answer was no, no, no. Third visit, the husband came to us and said, please do not tell the lady, but he knew that she was an adopted child from Calcutta. So that is the reason for the E trait there. Otherwise, it's not common in the resident population. So sometimes you get these odd situations where confidentiality matters a lot. Please know about possible pitfalls, like we saw in the last 4 or 5 examples. And I'm sure people who worked more with Hplc will have more examples to share. But the important thing is, no technology is foolproof. We must be keeping our eyes and ears open and using other technology or even simple tests like that sickle test, which help. Suppose we had not given it to the PG and reported off as S, nobody would have known. So that small thing. So it is after that we made it a practice. All sickle diagnoses have to go through a sickling test, whatever your conviction may be. And remember, other techniques may be required at times, sometimes complex like molecular, or sometimes as simple as a sickle test or a CBC might be contributing to what you're looking at. The example where we had a thal major misdiagnosed, nobody will believe that this patient does not have thal trait looking at the indices. So in the indices are telling you this has to be a thal major. That is why the reworkup was done. Thank you so much.
Wow, thank you so much, Dr. Kakkar. Wonderful presentation. There are a lot of questions, queries, clarifications, both on the YouTube as well as on the Google Meet. I have copied some of them for you on the chat, but I'll read it out for you.
Right.
If you could just stop presenting so that we can see you on the screen.
Okay, there.
Yeah, there, thank you so much. Just to tell you one more small thing is that there is a half a minute lag between the Google Meet and the YouTube transmission. So whatever you are saying, if there's any cross questions from there or clarification, it'll take us some time. So I think we have to just wait a bit. So I'll just read out the questions one by one. And it starts with Dr. Sudipta Naskar from YouTube. He says, in case number 2, which you presented, what does the peak just before HbF indicate?
I probably need to go to my, one second, I'll open it. I'm not sharing, but
Yeah, you can present, you can start presenting. You can share also if you feel like, no problem. You can
I'll just speak out just like that, yeah. So those are just minor initial peaks, degradation peaks only, nothing. So before F, it is only very minor peaks which will contribute to maybe 0.2 or 0.3%. They are minor starting degradation peaks, nothing to be worried about.
Right. Dr. Chatterjee has a question here. She says, difference between E heterozygous, D Iran and E homozygous, please.
Okay. So it's basically a game of percentages. E trait will be about 20 to 30%. D Iran will be about 40 to 46, 48%, and E homozygous in the same band or the A2 region will go beyond 80%, 80 to 90%.
Right.
And obviously, sorry.
Yeah.
If the percentages are like that, the peaks will go on becoming taller and darker.
Right. Dr. Nilesh Kapadia from Ahmedabad, he says, like to know about which compound heterozygous are beneficial and which are more severe.
Okay, so your E beta and S beta are most problematic, but your D beta thal is not. So it's the S beta and the E beta that you need to be more careful about, and in areas where you have an S or an E combination, there also patient may be more symptomatic.
Dr. Kapadia has another question which says importance of P3.
Okay, so P2 and P3 are both glycosylated peaks. So if I say in this, in one of the Hplc runs, if you look at your peak, let's say hemoglobin A0, which we said the major hemoglobin is 80%, P2 is 6 and P3 is 7%. What this means is 80 plus 6 plus 7, that's 93% of hemoglobin A. So practically if you're dealing or looking at hemoglobin disorders per se, we are not really worried about P2 and P3. We need to just add them to A0 to give you the normal A. But if you find them abnormally high, 12, 15% or 10%, then you might be incidentally picking up a patient who is diabetic who may not know. That's the only thing. So, and then you can probably refer them to the biochemist for a fasting sugar.
Right. Fine. Just let's wait and see if there is any other question on the YouTube or anyone here in the Google Meet would like to say something. Right, now we have some comments. We have Dr. Nilesh Kapadia saying, wow, wonderful presentation. Dr. Chatterjee says, thank you, sir, wonderful presentation. Dr. Shashireka Bhatt says, excellent presentation, thank you. Dr. Chatterjee has, for HbFH is beta than short.
Okay, beta thal short program, is it enough?
Yeah, thal, okay.
So I do not have much experience with HPH reporting here. I would probably think if you can bounce this question to somebody who knows better, but electrophoresis might be required because of faster moving hemoglobin. You may require electrophoresis or a molecular method alongside. There are pointers, but I'm not really sure on that.
Okay, Dr. Nilesh Kapadia says, degraded sample, do they show peak?
Yes. So it's like invariably, unless you're in a very high throughput center, you will want to store samples before you run. You can't run two at a time, two in one go. You will want to batch it up for HPLC often. In that case, if your storage time goes from 7 days to 10, sometimes 2, even 3 weeks, some centers keep it. At 4 to 8 degrees, pretty much stays stable. But if your pre-analytical variables before the sample came to you was already affected and then you're storing it longer, you may have degradation peaks. In that case, expect a flutter-like pattern where your waves are not smooth or your chromatograms are not smooth and you have multiple broken up peaks. Please do not try to interpret on that in any case, just ask for a repeat sample. It's a mess otherwise.
Right. Dr. Nilesh Kapadia says, excellent presentation, sir. Thank you.
You're welcome.
I think we are done. I think there are no more questions. Dr. Vikas Dubey says, thank you, sir. Wonderful presentation.
He's being kind. He works with me.
He better. Okay, so I think we are done. So Dr. Nilesh Kapadia needs more of him. So he wants you to come more and more on this channel and teach us more and more things. I will definitely agree with Dr. Nilesh Kapadia. And I know you are very busy, but then I think after 2 months or maybe 1.5 months, we'll again request you to come and speak on something which is really interesting for you, on which you would like to teach us.
Sure, sir.
So I would like to thank Dr. Kakkar. Thank you, sir, so much for coming on this platform and teaching us from the ABCD of HPLC to right up to the pitfalls, to making us understand that the area below the curve is as important as the peak. And further, to add on to that, the final slope is equally important. Otherwise, we might rush in to make some mistakes. Wonderful presentation, sir. Excellent. And I'm looking at the YouTube parallelly because they're writing one or the other. I'm getting distracted. Dr. Shashireka says, Nadeem, my question has not been answered. What was Dr. Shashireka's question? I did not see her question. Dr. Shashireka just wrote, excellent presentation, thank you. Okay. Anyway, I haven't seen her question, so we'll conclude here. Thank you so much, sir, for this wonderful presentation. It was wonderful to have you here. God bless you. Good night. Take care. Please share the PDF, and we would be, sharing it with everybody. Thank you so much, sir. Take care. Bye bye.
Okay. Bye, sir. Thank you.
Thank you. Bye.